welcome to the PTO on Ice Daily Show. My name is Christina Prevalence. I am one of two lead faculty for Modern Management of the Older Adult. We teach 3 courses. We have Modern Management of the Older Adult Live, where we actually have a course this weekend, which I will not be at. Dustin is going to be lead faculty there. We have our online course. We have our 8-week online course, Essential Foundations. And we have our first ever inaugural course of Modern Management of the Older Adult Advanced Concepts, where we deep dive and expand on a lot of the work that we did in the 8-week online course and our live course and build on it in different populations. So our Advanced Concepts course, we actually deep dive into an intensive balance assessment, neurological exam, different cardiovascular health issues like congestive heart failure, cardiac rehab. We go into urinary incontinence, masters athletes, arthritis, a whole bunch of special populations, as well as go into a little bit of the business side of things. So if you guys are interested in our online Advanced Concepts course, our next one starts March 11th, literally next week, a week today. And that's our inaugural cohort. So we're super, super excited to be offering that to you. You are seeing a very sad weightlifter today because if you guys weren't listening to the news, it was showing that the Arnold Expo got canceled. So I was supposed to be competing as a 71 kilo lifter at the Arnold's for American Open Series, and unfortunately the whole expo got canceled. The weightlifting competition is still going, but spectators are not allowed to be viewing it. So we've decided to not go. They did that as a precaution for COVID. And so we're super sad, but we're unfortunately not competing this weekend. And I know there's a lot of people who are really disappointed because it's a big deal. There's hundreds of thousands of people that come into Columbus, and there's going to be quite a bit of economic consequences, unfortunately, as a result of this. And this is just another precaution that the World Health Organization has put in place about the public gatherings. And I know that there's some talk about the Olympics and things like that and how they may not potentially be happening. So crazy. That's more Fitness Athlete Friday, but my little sad face is going to be on the podcast today, so I thought I would mention it. Okay, so content for today, we're going to be talking a little bit about shoulder replacements. Traditionally, when we think about arthritis, we're talking a lot about lower extremity arthritis, so hip, knee. But over the last several years, especially I think in the last 10 years, we've been seeing a lot more surgeons who are dabbling into shoulder reconstruction, so complete shoulder replacements, glenohumeral joint arthritis. And so I thought we would talk a little bit about what we kind of know about rehab and the surgery of a replacement in the shoulder, and then what we know that we as PTs can be doing about it. And so the first thing is that the prevalence of a joint replacement compared to a knee or hip is 10%. So for every 10 knee replacements that get done, 1 shoulder replacement gets done. So it is a much smaller population. However, that population is growing. We think that the prevalence of symptomatic shoulder pain that may have some relation to, sorry, my phone is going off, some relation to the glenohumeral joint arthritis is about 16%. Based on cadaver studies, again with the discordance between pain and imaging, we think that arthritis in the shoulder can develop in about 35% of older adults. Again, we're still just kind of guessing on prevalence because the literature on this is fairly sparse actually. And so that's just based on cadaver studies and kind of looking through sequential cause of death for individuals on autopsy. From there, people now are going through conservative management to try and look at how to help with shoulder arthritis. So some of the things that have been looked at the literature is obviously early PT intervention, trying to increase range of motion, reduce pain, and increase function and resiliency for individuals with long-lasting shoulder pain. And from there, individuals have played around with the things like use of cortisone as a method of easing pain in the shoulder. And then from there, the care pathway has often been looking at surgical management. And a study that was published last year was saying that, we should be trying conservative management for at least a year before we have thought about trying to trigger that cascade for surgery. And they considered conservative management not just PT, and a good portion of it was other medical management opportunities like cortisone and different topical NSAIDs and different types of pain management regimes. So if you have an individual who has kind of failed in conservative management, their shoulder is getting worse. Generally, the clinical presentation of an individual with arthritis in the shoulder is a gradual, deep pain that often has a central or posterior presentation that has limited range of motion in almost all planes, most particularly external rotation, which can make the differential diagnosis between adhesive capsulitis and shoulder OA kind of difficult sometimes. And has crepitus that usually is happening when individuals are going into flexion and abduction. We are thinking that a person may potentially be a candidate, especially in combination with imaging that shows that there is glenohumeral OA, that they may be a candidate for replacement. So if you have a person that is going through replacement, what are some of the surgical options? The two main types of shoulder arthroplasty that are done are a total shoulder arthroplasty and a reverse shoulder arthroplasty, TSA, RSA. And over the last several years, particularly in the last 5, we've seen quite a flip between how many people are doing a total replacement versus a reverse. And what the reverse and total is speaking to is where we know that the shoulder is a relatively unstable ball and socket joint just because of the way that the glenoid cavity is affecting having congruency with the humeral head. And what they saw was happening with a total shoulder replacement is when they have cemented the prosthesis that they had quite a large amount of failures where there was honestly, there was the development of a subluxation of the replacement or a detachment of the replacement itself. So what they have played around with doing is flipping it. So where they will attach the ball is into the shoulder blade, into the glenoid cavity, and the prosthetic of the cup will go into the humerus. And what they've seen with that is a much higher success rate and a much lower replacement rate, or failure rate rather, in terms of dislocation. And so what are the indications for somebody to get a total shoulder replacement versus a reverse? The main driver is age and the integrity of the rotator cuff. And so if you have a impairment of the rotator cuff, whether it be a previous traumatic injury that is symptomatic with pain of the rotator cuff because of a partial or full thickness tear, or just on MRI leading into surgery, you show that you don't have a good attachment site of the rotator cuff, or you've had a full thickness tear, we know that full thickness tears, especially with age, increase even if people are asymptomatic for shoulder pain. Then the indication is to get a reverse shoulder replacement. And it's because you just don't have the dynamic stability. And with a reverse placement, it allows the deltoid to take over more of the work of stability rather than the rotator cuff itself. And that has created a huge change in the amount of failures in dislocations that have happened as a result of a shoulder replacement, which is really exciting. And that refinement didn't really happen until the late 1990s. So it's really just been over the last 20 years that we've seen a much more successful outcome from individuals who have had shoulder replacements. And that's why we're starting to see them become more and more popular. And if you have a person who you've seen for either a total shoulder replacement or a reversed shoulder replacement, age is also going to be a big defining factor. Usually a total shoulder arthroplasty is indicated for somebody who is slightly younger. The average age of a person getting a shoulder replacement is actually 76. So we are seeing people who are older. With people who are in their 80s, it's almost always going to be indicated that they do a reverse procedure. And research looking at success rate in replacements with age as a defining factor showed that using age as a reason to avoid doing a shoulder replacement is not actually contraindicated, and that their age isn't one of the big barriers to success. in regards to successful implantation and low rate of dislocation in individuals with a reverse shoulder replacement. So that's kind of cool because it was fighting that ageist life about some of the ageist sentiment in our healthcare system. And so if you're seeing an individual who has had a shoulder replacement, what are we going to do about it? So the British Medical Journal actually did a really nice postoperative guideline where it kind of compared and contrasted total knee, total shoulder, and total hip. In the total shoulder replacement, the amount of time spent in a sling is going to be very, very different depending on the surgeon. When I've seen anything from being completely immobilized with a sling for 2 weeks to 6 weeks. So it really does depend on the surgical protocol with the surgeon that you're working with. Then we're going to be starting passive range of motion, making sure wound healing is good. All of those initial acute care pathways where we see individuals, especially after rotator cuff surgery, it's going to be relatively similar. The biggest thing for the early weeks up until usually around it can be anywhere between week 5 and week 8, is limiting the amount of external rotation that is happening at the shoulder so that the prosthesis can cement and heal. And most of the time that's going to be the biggest precaution. So just like the hip precautions, which we know right now, which is almost ironic that I'm saying this because we know that from the research that they don't tend to reduce rate of dislocation, but the biggest shoulder precaution is limiting the amount of external rotation until you're in that week 5 to week 8 mark, depending on the surgeon and the protocol. And then from there, we're kind of doing the same thing that we would be doing with a lot of rotator cuff repair surgeries. So we're trying to optimize range of motion, start strengthening, starting with isometrics, going into active assisted range of motion, active range of motion, and then strengthening through range, going across that continuum, oftentimes going with the surgical protocol. So I've looked at protocols from Johns Hopkins, Sunnybrook in Toronto, to a whole bunch of different protocols and compared and contrasted them to the British Medical Journal guidelines that they posted. They have a really nice infographic, and in general, they're fairly similar. The timelines around when they're allowing individuals to get out of their sling and do things like start returning to activity is going to be different. It's really interesting in terms of what the British Medical Journal has encouraged versus discouraged and advised against. So it's encouraged things like cycling and tennis, but not throwing. So that to me doesn't really make sense. I think we do need to do a lot more work in regards to like why can we do tennis, which can have an overhead throwing movement, but we can't do a sport that requires throwing a ball. I don't really know. So I think there's a lot more research that needs to be done because it's actually saying to encourage tennis and not to advise against sports that require throwing. And that to me is kind of like, that doesn't really make sense. But as we're starting to see more and more surgeons take on shoulder replacement surgery, and we're seeing the success rate be really high, and right now our success rate for the prosthesis lasting over 10 years is over exceeding 85%, which is really a great statistic. So we know now that the prostheses are lasting longer, and so now we can start really deep diving into some of the research on this. And so again, this is one area where PTs can get really involved, and knowing the difference between a shoulder arthroplasty and reverse, I think, is really important because it's going to tell us about the integrity of the shoulder going into surgery and can give us a little bit of an idea around what our prognosis in regards to range of motion may be. People are absolutely going to surprise us, but we may have somebody who has a lot of other issues potentially going on in the shoulder if they're getting a reverse replacement. All right, I hope you guys found that helpful. I've been really nerding into some of the research, and I'm really surprised around how little we actually know about how PTs can get involved, and any return to movement protocols are relatively sparse in regards to the literature. So these protocols are being made largely based on what we know in rotator cuff repair and in conjunction with what we know about joint replacement in general and healing timelines. And so I think we need to see a lot more happen before we have a really good look at what we need to be doing as PTs, but definitely something that's going to be coming up more and more in your practice, and something that we can be doing to be helping people return to all the activities that they want to be doing. All right, have a really, really great rest of your week. I can't believe it's already Wednesday. If you guys are looking to sign up for our online Essential Foundations or Advanced Concepts, you can head to ptonice.com/courses and you can sign up. We are doing our inaugural cohort of the Advanced Concepts course, which we are going to be talking all things arthritis, including shoulder replacements. So if you want to deep dive more into this topic, I encourage you to sign up. All right, have a great day, everyone. Bye.
Hey, thanks for tuning in to the PT on Ice Daily Show. If you enjoyed this content, head on over to iTunes and leave us a review. And be sure to check us out on Facebook and Instagram at the Institute of Clinical Excellence. If you're interested in getting plugged into more ICE content on a weekly basis while earning CEUs from home, check out our virtual ICE online mentorship program at ptonice.com. While you're there, sign up for our Hump Day Hustling newsletter for a free email every Wednesday morning with our top 5 research articles and social media posts that we think are worth reading. Head over to ptonice.com and scroll to the bottom of the page to sign up.